Hello.
Hello.
Yeah, sir, you are live now.
Yeah. Hello. I'm Dr. C.B. Patil. I'm a former professor and head of the Department of Cardiology at St. John's Medical College. Now I am a visiting professor to Manipal Hospital, Airport Road, Bangalore. And I am also a visiting cardiologist at Sri Shankara Cancer Hospital and Research Center, Shankarapuram, Bangalore. I am going to talk on acute rheumatic fever and its evaluation and management as on today. As you know, acute rheumatic fever is a post-infectious non-suppurative sequela of a pharyngeal infection. Non-suppurative sequelae of the pharyngeal infection with Streptococcus pyogenes or group A beta hemolytic streptococcus. It's due to a delayed immune response. And there are various types of streptococci. What are more common to cause acute rheumatic fever are M types like 3, 5, 6, 14, 18, 19, and 24. It is an immunologically mediated multisystem connective tissue disease caused by individual susceptibility along with environmental factors and bacterial interactions. It affects the joints, skin, subcutaneous tissue, brain, and heart. Except heart, all other effects are reversible. Its sequelae is the major cause of cardiovascular deaths in children and young adults. That is the main worry. Is there a decline in acute rheumatic fever and rheumatic heart disease in India? Data suggest decline of RSD from 5.3 to 1 per thousand between 1970 to 2010. ICMR data done between 2000 to 2010 studies, rheumatic heart disease 0.2 to 1.1 per thousand and rheumatic fever 0.007 to 0.2 per thousand as studied in 10 different urban locations. Echo has added new dimension to the disease burden, which is 10 to 20 times higher prevalence of silent. Hello?
Yes, sir. Sorry to interrupt you, sir.
Yeah.
Sir, are you changing the slides?
Yeah, I am changing already.
Sir, okay. Actually, on my screen, now when I'm viewing your screen, I'm only able to see the first slide.
No. I am already changing it.
I'm not able.
It has changed in my this thing.
No, sir. Over here, the slides are not getting changed.
Then why don't you recheck again?
Just a minute. Just, sir, stop sharing. Yeah. Now it has got changed. Now it was changed.
But now I am unable to see my screen, no?
Yes, sir, because you have stopped sharing, share it again.
Just see.
Yeah, now I can see the change slide.
Change slide, I will make it now full screen.
Yes, sir, you can.
It is changed. Now I will just change the third one. Is it okay?
Now also I am able to see the fourth slide only. Is there a decline in ARF RHD?
Then why it is not changing?
Just click on the third slide from your end.
Now
the slide has changed.
Then I think I have to do something here because full screen is not there.
Okay.
I have to go to the slideshow, I think.
Yeah, you can click on slideshow. Yes.
Then
click on slideshow.
Then I have
From
to,
beginning.
from beginning, I think.
Yeah.
Just see now. Acute rheumatic first slide has come.
No, but now again on my screen I'm able to see the fourth slide only.
It is not changing.
No, sir, it is not changing.
Why it is happening like this?
Yeah, now it has changed. Now it has changed.
Huh?
Now it has changed.
Now I have to do it full screen, then it doesn't change. Let me see now. I will do here changing. See now, full screen.
Now also I'm able to see the title slide only.
Arre. Previous, go to slide. Next. Is it changing now?
No, sir.
Previous, see now. Full screen is there.
No, sir. Now also the slides are not changing.
And then what I should do now? You must direct.
Stop sharing, sir.
Stop sharing.
Now the second slide. Yeah. Before you stop sharing, no, then I was able to see the second slide.
No. I will share the screen now.
Okay.
Just see.
Yeah.
Then I will click on the. Now I will do it a full screen. Now see, is it changing now?
Click on the third slide, sir.
Now it is. I am changing my slides here.
But here it is not getting changed.
Let me see. I think I have to keep
Now it has changed. Now I am able to see the first slide.
First slide full is there?
Yeah. In which your title, your name is there.
Is it a full slide?
Yeah, full slide is there. Yes.
Then shall I change like this only or what?
Just try to change it. Just click, come on, second slide.
Now?
Yeah, now it's there.
Now?
Third slide is there.
So here I can't see the full screen. Is it okay?
Yes, sir, it is okay. It is okay, sir.
Shall I start now again?
Yes, sir. Yes.
Yes, you want me to again introduce myself?
No, sir, you can start with the presentation.
Yeah.
And sorry, sir, for the inconvenience.
Yeah. Acute rheumatic fever is a post-infectious, non-suppurative sequela of pharyngeal infection with Streptococcus pyogenes or group A beta hemolytic streptococcus due to a delayed immune response. And various types of streptococci are there, like M types 3, 5, 6, 14, 18, 19, and 24. Very rarely, it is also caused by skin infections, as in indigenous populations like high-risk populations. It's an immunologically mediated multisystem connective tissue disease caused by individual susceptibility along with environmental factors and bacterial interactions. It affects joints, skin, subcutaneous tissue, brain, and heart. Except heart, all other effects are reversible. Its sequelae is the major cause of cardiovascular deaths in children and young adults. So that is the main worry from rheumatic fever. Is there a decline in acute rheumatic fever or rheumatic heart disease in India? Data suggest decline of rheumatic heart disease from 5.3 to less than 1 per thousand between 1970 to 2010. ICMR data between 2000 to 2010, rheumatic heart disease incidence was 0.2 to 1.1 per thousand and rheumatic fever 0.0007 to 0.2 per thousand as studied in 10 different urban locations. Echo has added new dimension to the disease burden, which is 10 to 20 times higher prevalence of silent rheumatic heart disease versus manifest RHD. Recent study, eco-prevalence of RHD in school children using World Heart Federation 2012 criteria is 7.7%, which is definitely significantly higher prevalence. Hence, we should cover them with a secondary prophylaxis if they are suffering from acute rheumatic fever. So, in a susceptible host with like a low socioeconomic status, like environmental factors, poor nutritional status, overcrowding, malnutrition, if they are there, and repeated group A streptococcal infections can occur in a susceptible host. Who is a susceptible host? There can be a genetically determined host factors may be there in them also, and precipitating event is a infection with a strain of group A streptococcus carrying specific virulent factors. So once that antigen enters there, there's a molecular mimicry between group A streptococcus antigens and host factors, leading to exaggerated T cell mediated immune response. And that further leads to first episode of acute rheumatic fever. If it is treated fully, probably there may be this thing, but because of the environmental factors with a susceptible host, there are chances that repeated and ongoing infections possibly driving the valvular inflammatory response, and episodes of recurrent rheumatic fever can be there, leading to established rheumatic heart disease. This is the main pathogenesis of the acute rheumatic fever and rheumatic heart disease. So hallmark of acute rheumatic fever is an exudative and proliferative inflammatory reaction involving the collagen and connective tissue, primarily of the heart, joints, brain, and skin. And rheumatic fever, hence it is called as it licks the joints but bites the heart. So what is the main pathology in rheumatic fever? Is an Aschoff nodule, which is pathognomonic of carditis. And valvulitis is responsible for main principal clinical manifestations: edema, cellular infiltration, hyaline degeneration, eventual fibrosis, and it can lead to calcification also. So what are the definite established lesions in a rheumatic heart disease? Isolated mitral stenosis can be there in 25%, combined mitral stenosis and regurgitation in another 40%, mitral with an aortic wall disease in 35%, isolated aortic wall in hardly 3 to 5%, tricuspid valve involvement can be there in 6%, whereas in pathological studies it can go up to 30%, like autopsy studies. All three involvement is hardly 1%, but definitely it leads to a lot of morbidities and mortality. So the diagnosis of rheumatic fever is done by Jones criteria. So there are major criteria. They are very specific criteria like carditis, polyarthritis, chorea, subcutaneous nodule, erythema marginatum. But minor criteria which are less specific like fever, polyarthralgia, raised ESR, C-reactive protein, leukocytosis can be there, and ECG, there may be a prolonged PR interval. Hence, they are all less specific. But along with these major and minor criteria, there should be a supportive evidence of preceding streptococcal infection, which is essential, except only when chorea, which is a very late manifestation, that may not need all the other streptococcal evidence. So what is the evidence of a recent streptococcal infection? Either in the form of anti-streptolysin O, ESO titer more than 333 units in children and more than 250 units in adults, and anti-deoxyribonuclease B, and the titer more than 140, 400, 1 in 480 units in school children and 1 in 340 in adults. If these are raised, definitely that indicates that there was a preceding streptococcal group beta hemolytic streptococcal infection. And in case history of within 45 days a streptococcal sore throat and scarlet fever if they're there, or a positive throat culture if it is proved, or a positive rapid streptococcal antigen detection test They also suggest that recently must have suffered from a streptococcal infection. So diagnosis of ERF, the sensitivity sensitivity of the modified Jones criteria are sensitivity is 77%, specificity is 97% respectively. There is no single laboratory test that is 100% sensitive or specific for the diagnosis of acute rheumatic fever. ASLO cutoff values are not adequately standardized in all populations. Throat culture is hardly positive in 1/4 to 1/3 of patients. So that's why in 2015, American Heart Association revised the Jones criteria, because the global distribution of acute rheumatic fever and RHD is disproportionate in various countries. New advances in epidemiological data along with technological advances of ECHO led to revision in 2015. ECHO diagnosed subclinical valvulitis has been accepted now as a major criteria. And clinical utility depending on low risk or a high risk population to avoid over or under diagnosis of rheumatic fever. What is low risk population is acute rheumatic fever incidence of less than 2 per 1 lakh school age children between 5 to 14 years per year, or an all age rheumatic heart disease prevalence of less than 1 per 1,000 population per year. So this is what is called as a low risk population. Anything more than this, they all come under high risk populations. Some of the parts of India, they also come under high risk, like tribal people, all these things. Clinical entity of possible rheumatic fever also has been entertained when clinical suspicion is present without all lab facilities, when 12 months secondary prophylaxis and re-evaluation with ECHO for further continuation of secondary prophylaxis is very much required in this possible rheumatic fever. So in low risk population, what criteria have been advised in AHA 2015 is carditis, either clinical or subclinical. Subclinical means proved by the echocardiography criteria. Arthritis is only polyarthritis in low risk populations. Chorea, erythema marginatum, and subcutaneous nodules. And the minor criteria in low risk population is polyarthralgia, fever more than 38.5 degrees, ESR more than 60 millimeters in the first hour, and or C-reactive protein more than 3 milligram per deciliter, and prolonged PR interval, which after accounting for the age variability. So these are in low risk population. And similarly, they have also advised Jones criteria in high risk or a moderate to high risk population. Carditis could be clinical or subclinical. Arthritis, here it could be including polyarthritis, monoarthritis, even a polyarthralgia is taken as a major criteria in high risk populations. Chorea, erythema marginatum, subcutaneous nodules are there. And in as a minor criteria, there can be a monoarthralgia, fever more than 38 degrees, and ESR more than 30 millimeters in the first hour, and C-reactive protein more than 3 milligram per DL, and prolonged PR interval as per the age criteria. So these are the changes have been done in 2015 AHA Jones criteria modification. Now coming to the arthritis, it is almost seen in 75 to 100% of acute rheumatic fever. Here the pain is very severe with minimal signs, and definitely it relieves with salicylates, with an adequate dose of salicylate within 24 to 48 hours. And as in older children, often seen in older children, as the age advances, arthritis is more common, whereas very young age, it is the carditis is very common. Often asymmetric migratory polyarthritis in almost 35 to 66, 1/3 to 2/3, and affects larger joints mainly in the lower limbs like knees, ankles, later elbows, wrists, all these things. Even sometimes 6 to 16 joints can be involved. Hips, spine, axial joints, and small joints are rarely affected. Each joint is inflamed for few days to a week in almost 2/3 of the people, but rarely it can remain up to 3 to 4 weeks, and often it is a self-limiting, doesn't give rise to any residual this thing. Whereas there's one entity called as Jacquard's arthritis, which affects the hands with a hyperextension of the metacarpophalangeal joints and flexion of the interphalangeal joint, swan neck difference. So that rarely it can be there in rheumatic fever. It's a correctable deformity. Later, it can lead to a fixed deformity. When arthritis is considered as a major criteria, monoarthritis or polyarthralgias can't be taken in the same patient as a minor criteria. And monoarthritis is seen in 16 to 18% of people in high-risk populations. High-risk population, I told you already, some of the tribal areas here in India, as well as in Australia and New Zealand, there also some tribal areas are there, where it's more common. Arthralgia versus arthritis, and it is more common in developing nations and indigenous populations, as I have already told you. And first attack in rheumatic fever is more often arthritis. Should it be a major criteria, arthralgia? 2 out of 81 patients with polyarthralgia developed mitral stenosis at 5 years of follow-up. Hence, it is important. No difference between patients presenting with polyarthritis or polyarthralgia. In India, polyarthralgia is more common than polyarthritis. It is still considered as minor criteria in low-risk population, but can be a major criteria in high-risk population after excluding other causes of polyarthralgias. And hence, it should be differentiated from post-streptococcal reactive arthritis, rheumatoid arthritis, serum sickness, Henoch-Schönlein purpura, acute leukemia, viral fevers, systemic lupus erythematosus, collagen disorders, Lyme disease, and sickle cell disease. So what is a post-streptococcal reactive arthritis? It occurs within 10 days, unlike rheumatic arthritis, which occurs almost 14 to 21 days later. And here it is persisting and relapsing over weeks to months. Whereas there in rheumatic arthritis, migratory, transient, remains for a week and resolves in 3 weeks, and mainly involves the large joints. In post-streptococcal reactive, no major criteria of ERF. Here in major criteria of ERF are there. It's a slow partial response to aspirin or NSAIDs, whereas in rheumatic fever, it's a prompt response to aspirin. And in streptococcal reactive arthritis, 5 to 7% chance of wall involvement still can be there, whereas there it is almost 90% chance of wall involvement following carditis or subclinical carditis. Hence, even a post-streptococcal reactive arthritis, they also need temporary penicillin prophylaxis, and definitely a minimum an year follow-up should be there just to know, is it a rheumatic fever causing the wall damage, or whereas in a rheumatic arthritis definitely needs prolonged or a lifelong penicillin prophylaxis. Now coming to the carditis, it occurs within 3 weeks of pharyngitis. Incidence is 40 to 91%, both clinical and subclinical. And as I told you, less than 3 years, its affection is 90 to 92%, 50% in the age group of 3 to 6 years, and 32% in teens, and 15% in adults. So as the youngest the age, more carditis, and it causes morbidity and mortality. Clinical carditis, 40 to 60% in case of rheumatic fever during first attack can occur, and it is diagnosed by audible murmur, pericardial rub, or a heart failure, and change in the murmur or a new murmurs. So changing murmurs, pericardial rub, evidence of heart failure, they all indicate that there is a carditis. It may be asymptomatic and often detected by echocardiogram, where it is called as a subclinical carditis, which can be there in 18% of acute rheumatic fever patients. Pericarditis occurs in 10 to 15%, usually chest pain, pericardial rub or mild effusion can be there. Myocarditis is rare without valvulitis, hence manifests as cardiomegaly, soft heart sounds, a third heart sound may be heard, heart blocks can be there. Rarely there can be a heart failure also in a myocarditis. Endocarditis, definitely it's very important, most important and consistent. Severe endocarditis can lead to congestive heart failure in 5 to 10%. MR is usually seen in 90 to 95%. It may be associated with AR in 20 to 25%. Isolated AR is very rare, less than 5 to 8%. Transient apical mid-diastolic murmur like Carey-Combs murmur can be heard. And in 50%, cardiac damage occurs much later. Hence, a definite follow-up is required in all those who have suffered from an acute rheumatic fever. The role of echo is very important. It confirms the clinical findings and allows assessment of severity of valve involvement, chamber size and ventricular function, presence and size of pericardial effusion. Serial assessment of disease progression can be assessed to exclude, of course, congenital heart disease and infective endocarditis, and to decide to discontinue prophylaxis. What are the echo features? They are very important. Thickening of leaflets, echogenicity of submitral structures, beaded appearance of leaflets, mitral valve or aortic valve or a tricuspid valve prolapse, mitral regurgitation, aortic regurgitation, tricuspid regurgitation can be there, reduced mobility of valves, caudal tear, pericardial effusion can be there. So you can see these are the echo pictures. The first one is a 4-chamber view of the mitral valve. You can see the thickened beaded appearance of the mitral valve, almost like even in a short axis you can see the mitral valve. And in the fourth picture, it is the aortic valve thickening is also seen, and submitral structure also appear more echogenic. Now, what is a pathological mitral regurgitation? Because sometimes very small jets can be seen physiological. That's why you must detect, is it pathological? What is pathological mitral regurgitation is seen in at least 2 views. In at least 1 view, jet length should be more than 2 centimeters equal to 2. Peak velocity should be more than 3 meters per second. Pansystolic jet in at least 1 envelope should be there. Similarly, what is pathological aortic regurgitation? It is seen in at least 2 views. In at least 1 view, jet length is more than 1 centimeter. Peak velocity more than 3 meters per second. And pan-diastolic jet in at least 1 envelope should be there. So you can see here, you can see acute, there is a mitral regurgitation jet along with thickening and beaded appearance. The walls are there. Here you can see the aortic regurgitation jet in this case. So here there is a clinical, what's the echocardiographic study? The clinical study, mitral regurgitation hardly seen in 144, whereas when along with echocardiography, it was seen in almost 210. That means definitely the echocardiography is going to detect both the MR, aortic regurgitation, tricuspid regurgitation to the maximum extent compared to the clinical detection. That's why it's very important. Subcutaneous nodules, incidence is hardly 1.5 to 3%, may be associated with severe carditis or prolonged active carditis as a late manifestations. Characteristics, small, round, firm, painless nodules, almost size of 0.5 to 2 centimeter on external aspects of large joints, on forearm or legs, ankles, rarely occiput or spine, symmetrical, occur in crops, freely mobile and not inflamed. And they, of course, they persist for few weeks, rarely more than a month. So they later disappear. Subcutaneous nodules and chorea are late manifestations of acute rheumatic fever and do not indicate activity. So this is subcutaneous nodules you can see here. Erythema marginatum, often seen in patients with carditis. What is erythema marginatum? Is a serpiginous or circular macular, non-pleuritic pink rash extending centrifugally with irregular borders on trunk and proximal extremities, not in the distal arms. Evanescent, there is very transient, non-indurated, lasts minutes to more often a day, occurs after a shower, blanches on pressure, early or a late manifestation, hardly seen in less than 5% of rheumatic fever patients. Arthritis, erythema marginatum and carditis indicates active rheumatic fever. So this, you can see the erythema central blanching is there, and active periphery is there. You can see erythematous margins. Chorea, Sydenham chorea, otherwise called as Saint Vitus dance or a chorea minor, is an involuntary, semi-purposive, irregular, jerky, rapid movements, often disappear during sleep. Involves upper limbs, face and lips, feet and legs. Muscular weakness can be there, hypotonia can be there, and emotional lability. Often laughing, crying can be there. Occurs in 20 to 40% of patients with rheumatic fever. Often in pre or a post-pubertal females, it is often seen. May coexist with carditis and or murmurs. Appears 1 to 6 months after sore throat, but reasons not known, but usually lasts 8 to 15 weeks. May last from 1 week up to 2 years also. But the treatment is, of course, you have to treat the streptococcal sore throat, and that means benzathine penicillin prophylaxis is required. Haloperidol, carbamazepine, and rarely valproic acid are helpful to relieve the symptoms. Lab reports may be normal because it occurs very late and needs secondary prophylaxis in all the patients. Minor manifestations, fever, a cutoff value of more than 37.5 would allow the diagnosis in 90% of suspected cases of acute rheumatic fever. In low-risk populations, fever associated with ARFs usually exceeds 38.5 degrees. It usually decreases in a week. Low-grade fever can last 2 to 3 weeks. Tachycardia is most often out of proportion to the fever. Even sometimes, that's why we see always the heart rate at night. That should be settled. Abdominal pain and anorexia may also indicate there may be a mesenteric adenitis also in these people. Minor criteria, ECG prolonged PR interval can be seen in 1/3 of the patients of carditis. It's a non-specific finding. Tachycardia can be there. Sometimes the AV blocks, QRST changes may be suggestive of myocarditis. Leukocytosis 12,000 to 20,000 per DL can occur, and chest X-ray is useful in assessing cardiac size, heart failure, all these things. C-reactive protein is a beta globulin, normally not present in healthy individuals, uniformly present in all patients with acute rheumatic fever. It is raised earlier than ESR and falls faster than ESR. Normal CRP levels is a strong point against the diagnosis of acute rheumatic fever. So a cutoff more than 3 milligram is diagnostic of acute rheumatic fever. However, presence of CRP is not diagnostic as it may be positive in many infections. It is sensitive but not specific for acute rheumatic fever. Diagnostic if combined with positive anti-DNase B. ESR most useful in following the course of the disease. Strikingly increases during acute rheumatic fever. ESR more than 60 millimeter in low-risk individuals, more than 30 millimeters per hour in high-risk population. It may be suppressed to normal levels in the presence of CCF, raised when treated or increased in the presence of anemia, often elevated for 4 weeks, rarely for 3 to 6 months. Usually returns to normal as rheumatic activity subsides. That is the importance. So it has to be followed up if is there any rheumatic activity or not. So evidence of previous streptococcal infection. So it's mainly we depend on the anti-hyaluronidase, anti-DNase B, and type-specific antibody, anti-A carbohydrate antigens. Coming to the ASLO titers, the raised ASLO indicates recent group A streptococcal infection. It is increased in 80% of the individuals. Titers vary with age, geographical area, presence of other infections. Detectable following group A streptococcal infection within 7 to 10 days. It peaks at 3 to 6 weeks, declines to pre-infection levels in 6 to 12 months. Diagnostic if combined with anti-DNase B, which is very specific, and its titers in children is more than 240, adults in more than 120 odd units. Whereas the ASLO titers in children it should be more than 330 odd units, in adults it should be more than 250 odd units. And so at least 2 samples, 2 to 4 week intervals, if they are showing rising titers, definitely that is suggestive of a previous streptococcal infection. Now, coming to the treatment of an acute episode of a rheumatic fever, hospitalization for severe carditis as well as arthritis, and if they are suffering from chorea is required. Bed rest if severe pain, like arthritis, at least 2 weeks are required. Whereas if there is a definite carditis with congestive heart failure, definitely the prolonged bed rest is required till the failure subsides and other parameters like CRP, ESR, everything comes down. Current medical therapy only relieves symptoms but doesn't change the natural history of the disease. Treatment of group A streptococcal pharyngitis is by penicillins. Of course, throat swabs for culture sensitivity just to prove it. Treatment of arthritis definitely with salicylates. After pain relief, supervised activities can be carried out later. Severe carditis with or without CHF, they always need steroids like prednisolone, 1 to 2 milligram per kg for 2 to 3 weeks, gradual tapering later over 8 to 12 weeks, and can be overlapped with salicylates for 10 to 12 weeks or more. So the total duration of therapy is at least 12 weeks. Treatment of congestive heart failure and arrhythmias by furosemide, mineral receptor antagonists, ACE inhibitors, beta blockers, they all can be used in the treatment of heart failure and arrhythmias. In severe mitral regurgitation or aortic regurgitation or a flail leaflet or a caudal rupture, definitely they need a surgical intervention immediately in the form of a valve repair. So recurrences, a new episode of a rheumatic fever following another group A beta hemolytic streptococcal infection occurring after 8 weeks of stopping treatment is called as a recurrence. Almost 1/3 suffer from recurrences. Without heart disease, if there's a definite recurrence, again you have to have a 2 major, 1 major, 2 minor, or a 3 minor criteria with a definite evidence of a gas pharyngitis. With RHD, at least just 2 minor criteria with evidence of a recent streptococcal infection is required. What is a relapse then? Worsening of rheumatic fever while under treatment and often with carditis or heart failure is called as a relapse. Then what is a rebound? Rheumatic fever occurring within 4 to 6 weeks of stopping treatment or while tapering drugs is called as a rebound of a rheumatic fever. Recurrences are harmful and constitute the most important prognostic factor. Recurrences increase cardiovascular mortality and residual heart disease also. Diagnosis, pericarditis or a new murmur or worsening cardiac status and supporting evidence of a group A streptococcal infection like raised ESR, C-reactive protein, all indicate that there is a definite recurrence. Carditis in first attack is more prone to recurrent attacks, often with carditis. Recurrences are highest in the first year after rheumatic fever. That's why you should be very careful and you must follow up with a secondary prophylaxis. And it decreases with time from the last attack and decreases with increasing age also. So how to prevent acute rheumatic fever? Because it is it causes heart damage in a very young and young adults. That's why we must prevent this acute rheumatic fever and rheumatic heart disease. So there are 3 ways. What's called as a primordial prevention, reduction of risk factors for group A streptococcal exposure and infection in susceptible individuals. The risk decreases to 90% by improving socioeconomic status, living conditions, hygiene, and use of anti-streptococcal vaccine. To improve environmental, behavioral, and cultural factors which increase the risk. Easy access to primary health care is also equally important. What is primary prevention? Antibiotics for group A streptococcal pharyngitis within 9 days to cure it. It decreases the attack rate of rheumatic fever by 70%. Intramuscular penicillin decreases rheumatic fever attack rate by 80% as proved by trials. Number needed to treat is 60 to prevent 1 rheumatic fever. Resistance to use because of anaphylaxis because injections, no, anaphylaxis, fear of reuse of needles, reactions. Of course, the anaphylaxis is very rare in children. So you need not worry, you must continue with the injectable benzathine penicillin. Intramuscular injection used under sterile condition, proper technique is required to decrease the pain of the injection. Oral penicillins, hardly few trials only, hence better to give injections. Limitation, 1/3 of acute rheumatic fever due to subclinical gas infection. That means almost 1/3 to half. They may not give history of a sore throat at all or a previous rheumatic fever. Asymptomatic recurrent gas infection triggers rheumatic fever. Controversies, there is no significant decrease in rheumatic fever in school-based sore throat clinic program. In New Zealand, in 22,000 children of 53 schools. There are no RCTs, but successful primary prevention program in Cuba and Costa Rica. So definitely in certain countries, definitely it's a successful program. It is cost effective, public health strategy in a comprehensive national program for rheumatic fever prevention should be adopted. So benzathine penicillin, what is the dose is 12 lakhs in more than 27 kg weight and 6 lakhs in less than 27 kg weight. To treat sore throat, it is a single injection, whereas for secondary prophylaxis, better is a 15 days you have to continue, whereas in our country usually you follow 3 weeks regimen, 21 days, but definitely in tribal people, high risk population, better to continue 15 days once prophylaxis with injections. Whereas those who are scared or don't want to take injection, penicillin V oral, children 250 milligram QID for 10 days, and for secondary prophylaxis, twice a day to be continued. Adults 500 milligram TID for 10 days for a sore throat, whereas for his prophylaxis, it should be twice a day 500 mg BD to be continued. Azithromycin and only when there is a penicillin allergy, they are given for sore throat for 5 days, 500 milligram for 5 days, 12.5 milligram per kg. Cefalexin also can be given if there is a penicillin allergy. Erythromycin is another drug which is given in penicillin allergy for treating sore throat. Prevention of ARF and RHD, secondary prevention to prevent recurrences. Clinical trial evidence is stronger for intramuscular penicillin versus oral. Evidence for IM every 2 weeks decreases recurrence by 50% versus every 3 to 4 weeks as advised by WHO. Duration of therapy, observational studies only. Individualized on socioeconomic status, a risk of exposure to gas infections. Carditis with or without valve lesion are at high risk for recurrent attacks. Need longer duration of prophylaxis or for lifetime if established RHD already. Tertiary prevention, catheter-based intervention or surgery to repair or replacement of valve to improve survival and decrease morbidity and mortality. So what is the duration of prophylaxis? Rheumatic fever and carditis and residual valvular damage, if it is already there, at least 10 years after the last episode and at least until the age of 40 years, whichever is longer. If there is a rheumatic fever and carditis, no residual valvular damage, 10 years or at least 25 years of age, whichever is longer. Rheumatic fever without carditis, 5 years or until 21 years of age, whichever is longer. So this is the duration. You have to continue the prophylaxis. So what are the future perspectives? Jones criteria are not sensitive or specific for high incidence for high risk population and need susceptibility test to increase its specificity. 2015 AHA revision has improved diagnosis in both low risk and high risk populations and identify those who are genetically susceptible, who are almost in 3 to 5%. By genome analysis, a predictive risk score, if added, can improve Jones criteria in future. Development of new long-acting, high-quality formulation of penicillin, which is affordable and easily accessible improves secondary prophylaxis. Development of safe, effective, affordable vaccine is a need, but it is difficult. Comprehensive national programs for primary and secondary prevention, preventive interventions to reduce acute rheumatic fever and rheumatic heart disease in endemic areas is very much required. With this, I thank all of you for having heard my lecture. And if there are any questions, I'll be very much pleased to answer the same. Thank you. I also thank the IJCP for giving me this opportunity. Thank you.
Hello.
Hello.
Yeah, sir. You can stop sharing your slides.
Okay.
And now we have some questions also that I will post in our chat section one by one.
Yeah.
So I have posted the first question.
Yeah. How prevalent are respiratory symptoms in acute rheumatic fever? Usually, it's very rare, but sometimes a pneumonia has been described in, but they are very rare. How does treatment of group A streptococcal infection affect outcomes for acute rheumatic fever? The treatment is definitely going to reduce the future infections. I told you, if it is treated within a week or two of the sore throat within 9 days, its occurrence almost comes to almost 70 to 80% reduction is there. But of course, later if they are exposed to repeated infection like overcrowding, malnutrition, the low socioeconomic status, all these make them to have a repeated respiratory tract infection, the sore throat infection with a group A streptococcus. Hence, they may need even future prophylaxis also. Hence, ultimately, it depends on what environmental they are there and what is their susceptibility for the group A streptococcal infections. So depending on that, you have to continue the secondary prophylaxis also in them. Thank you. What are the symptoms of congestive heart failure in acute rheumatic fever? Of course, congestive heart failure is the functional capacity we call by NYHA classification. So they will have a dyspnea, breathlessness. They will not be able to perform their duties, and they may not be able to walk much. Like a 6-minute walk test also may not be possible with a severe failure. So fatigue is another important symptom. So there can be breathlessness, there can be fatigue, there can be weakness. So these are the symptoms of a heart failure in acute rheumatic fever. Of course, these are the common symptoms in all other heart failures also. How effective is echocardiography in detecting carditis in acute rheumatic fever? Definitely, whenever if there is a definite murmur, it indicates that there is already a wall damage. For example, the person has suffered from a rheumatic fever or a sore throat and confirmed case, then murmurs may or may not be there on the long run. But definitely, if you do the echo in another almost a third or half, almost it has been described in 18% as subclinical carditis. That means murmurs may not be heard, but you may be able to detect the heart damage by echocardiogram. I have told you heart damage in the form of a thickening, beaded appearance, and echogenicity of the submitral structures, and pathological mitral regurgitation, aortic regurgitation, tricuspid regurgitation. All these things can be seen by echocardiogram. And of course, the volumes and the structure, and as well as the size of the ventricles, the ejection fraction, all these can be assessed by echocardiogram. What is the indication for surgery in acute rheumatic fever? Definitely, if there is a heart failure is secondary to valvulitis or a wall damage, most often due to severe MR. And if there is a severe MR, it may not come down with the medical line of treatment, whatever you do, whether it is and of course, even if you are treated with steroids, 4 to 6 weeks or 8 weeks or even 12 weeks, if the heart failure is continuing, then you can't just continue steroids. You have to subject him for valve repair or a replacement. If there's a sudden caudal rupture which precipitates the heart failure, then you have to subject him for a valve repair or a replacement. Hence, worsening heart failure is one of the indication, and of course, by severe MR, severe AR, if they are definitely there, if they are causing heart failure and volumes of the LV being increasing, the ejection fraction being coming down, definitely you have to send them for surgery early to safeguard them for further deterioration and more mortality.
Hello?
Yes?
Yes, sir. We have completed all the questions.
Thank you.
Thank you very much for your valuable time, sir, and sharing important insights on the topic in a very beautiful manner, sir.
Thank you.
We also learned a lot of things from here.
Thank you. Thank you very much. I thank the IJCP for this opportunity. Yes, I also thank all the doctors who have attended.
Okay, sir. Okay. Yes, sir. Yes.
Thank you very much.
Thank you, sir.
Take care. Bye.
Bye.
Shall I leave now?